Good evening, America, and welcome. It is that time again. It is the most important place for you to be tonight, and that is Fertility with Fink. I am Fink. You are friends. This is Fink and Friends, and it is so nice to be with you as we are every Tuesday evening at this time. It's 5 o'clock on the Gulf Coast, which means 6 o'clock in the East, 4 o'clock in the mountains, and 3 on the West. And this is the time that we get together to talk about all those things that are important to us, those things about women's health, those things about having a family, about making a family, all those things about fertility and IVF and everything else it takes for us to get there. So thanks so much for joining me here this evening. I have to say it is my favorite place to be of the entire week. Even just today, I saw a patient in the office here. By the way, I am a fertility gynecologist and the doctor at New Life Fertility in Pensacola, Florida. We also have offices in Panama City, as well as Mobile, Alabama. And I am also a fertility gynecologist at the Missouri Center for Reproductive Medicine, MCRM, with offices in Chesterfield, Missouri, or the St. Louis metropolitan area, as well as in Tulsa. We are happy to see you at any of our locations. Find us on the web. We are proud members of the First Fertility Network, making miracles happen every single day. And that's what we love to do. So I started to say that I saw a patient today in the office who said, Dr. Fink, I have been watching you I've been watching you for 2 years. For 2 years on the internet there. And I said, oh my gosh, I am so flattered. I really had no idea that I could be of such value, and it makes me really very happy to be a part of your lives, and I thank you for being a part of mine. A special good evening to V. Reese. You are the first person to join this evening right here on the New Life Instagram side. We've got a bunch of different feeds. We've got my feed here on Instagram, which is Randy Fink MD. We've got New Life Fertility over here, and right here in the middle, we've got Facebook, we've got YouTube, we've got LinkedIn, we've got MCRM. So we are all over the place tonight, wherever you're joining from. Happy to have you. Hi, Midgie. Good to see you. You are the first on my Instagram side there. Thank you for being here this evening. Marlena B, it's a pleasure to see you. And T. Andre, is that Tara? Nice to see you tonight. Haven't seen you around for a while. If that is who I think it is, it may not be. But if it's not, it's still nice to see you anyway. Folks, if you've got questions all about all those things fertility-wise, please throw them my way. That's what we're here for, to answer all those questions and to really try to take some of the mystery out of what it is we do and how to make things better, how to make things easier, how to deal with these problems as they arrive, because this whole process is a very difficult one and sometimes really hard to understand. That's my job, to make it easy for you to understand. For that, that's why I sit here every Tuesday evening. A special good evening to Sharmila. Hello, nice to see you and baby here tonight. Hi, Lisa. Good evening to you. And V. Reese, you're just all over the place. I have you here. I have you here. I'm just glad, frankly, that you're here. That means the world. So I had Sharmila says, Dr. Fink, my baby is PGTA normal, but recently she got diagnosed with droopy eyes, and ophthalmology is saying that there's a need for surgery. So what you're calling a droopy eyes is actually, there's a medical term for that. We call it ptosis. And you spell that, it starts with a P. The P is silent, Ptosis, ptosis. And oftentimes, in an isolated scenario, if all you have is just a little bit of ptosis of the eyes, that usually is something that is a muscular issue. It may have to do with receptors for the biochemicals that keep those muscles open. Ptosis is not an uncommon problem and is something that can be fixed. So I'm certain, Sharmila, that that is a worrisome thing because no one wants to hear anything that is potentially adverse about their baby. 100%. So it is scary, but it sounds like you're in good hands with that ophthalmologist because this is something that even though you had never, really considered it as a possibility with your baby, this is something that your ophthalmologist has seen a million times. So I think that you can feel comfortable and confident knowing that the ophthalmologist knows what they're doing there. That's what they do. So that's a good thing. Try to separate out, your anxiety over worrying about your baby, over, well, what, could really be at play here. And most of the time that is really just a muscular issue, especially because, as you say, you did PGT testing. So we know that your baby is believed to be chromosomally normal. That's 46 chromosomes. So not to have a genetic condition, or at least a chromosomal condition. Genetic conditions are things that we can test for through what's known as the genetic carrier screening test. And with that test, we typically do a test from mom and see if mom is a carrier of any of these known diseases. And there are a bunch of different panels that we can use for that. There are some of these panels that will test for 800 or even 1,000 different genetic diseases. In most cases, many of those diseases are things that are not dangerous. In my practice, we really just test for the 250 of the most lethal ones, the ones that are really bad, the ones that are really problematic. And if it turns out that mom is a carrier of one of those diseases, then we test dad for that specific disease. And if it turns out that both mom and dad are carriers of the same genetic disease, it gives you a 1 in 4 chance of having an affected baby. And so obviously the time that we want to find out about that is before you get pregnant, because we can prevent you from having an affected baby, if we're doing fertility treatments. So that's the way that looks. A special good evening to Angelina Foxy, nurse practitioner Angela up in the great state of Minnesota. Thank you for being here this evening, along with your baby, who I was happy to be a part of. And I got some pictures from my friend Angela there for just about I think it was 2 years ago that we did an embryo transfer that resulted in something very, very special that ended up landing in your house, didn't it? Marlena says, I was wondering if you have a BCL6 positive result on the Receptiva test, if that would alter the medication protocol for a retrieval, and if so, how? I think that's a great question, Marlena. So typically speaking, the BCL6 is a marker for endometriosis, as we know, and it's often something that we test on folks when they have recurrent implantation failure. That is to say, we're putting embryos back inside of them, but for whatever reason, despite the fact that those embryos should be sticking, they're just not sticking. So we can do this test for the BCL6 marker to see if endometriosis is present. If the endometriosis is present or BCL6 is positive, that tells me that endometriosis is causing an inflammatory response in the lining of your uterus, which is making you oppose your own progesterone hormone levels. And when you oppose that progesterone hormone, well, obviously progesterone, is the most important hormone that there is as it pertains to getting pregnant and even staying pregnant. So opposing that hormone means that that hormone can't do what it's supposed to do. So what do we do in that scenario? We treat you with medication. We suppress that endometriosis for I have been yawning all day here, people. I'm so sorry. You know what? I didn't get my coffee this morning. That's the problem. No wonder I have a headache here too. That's the reason that we test for it, so that we can suppress BCL6 and endometriosis for 60 days before doing an embryo transfer. So your question is, but what about retrieval? What do we know about retrieval? And here's what I'll tell you. Folks with endometriosis oftentimes have more, let's call them fragile eggs. The eggs themselves may be a little more sensitive to hormone stimulation. So, what does that mean to me? I really have to think about, is there an alternative? Is there something that we want to do a little bit differently as it pertains to an IVF stimulation? Like maybe we want to turn it down a little bit. Maybe we want to nuance those eggs instead of hitting them really hard and strong. That's the way I think of it. In practical purposes, many practices don't change the protocols, but it's always something that I think about in someone who is known to be positive BCL6. It means that in all probability, there's endometriosis there someplace, which means that maybe we do want to alter that stimulation regimen to be a little bit more gentle on those eggs, on those follicles, so that we can maximize the way your ovary produces eggs. Now, some people would think, oh, well, wait a minute, endometriosis, doesn't that mean quite the opposite? Doesn't that mean that you have to be stronger with my ovaries to try to get them to produce eggs? And the answer is nope. It actually can make those eggs seem more fragile than they actually are. And I hope that makes sense to you. Let's see. Jess Koval says, when in the cycle to start suppression for recently discovered endometriosis after 13 chemical pregnancies and 2 failed transfers. Holy cow, Jess, that is quite a history, and it sounds like that was a very difficult ride for you to be on. 13 chemical pregnancies and 2 failed transfers. So what we do there, if you have endometriosis and it was diagnosed through the biopsy, which is called receptiva, then we can really start the suppression at any time. Now, what we know is that if we use the medication at a random time, it may result in more irregular bleeding for you. So many practices will say, no, we're going to start your suppression when you get your period. I don't necessarily feel like people need to wait for a period to start that suppression, because it may just delay things all the longer for you. So my vote is really you can start it at any time. 60 days suppression. There is also some data that shows us that surgery is also a possibility there. Now, in my mind, using surgery to treat that endometriosis may not be as wise, especially if it was diagnosed non-invasively. That tells me that, well, gosh, you did a biopsy in order to avoid the surgery. Sometimes what happens is that there can be such a little bit of endometriosis when you look that the surgeon may actually even miss it. You can look inside and not see a thing, but it's enough to make that BCL6 positive in the endometrium. And so then the surgeon leaves and says, no, I think it must have been a false positive on the receptiva test, because I didn't see anything when I looked. And I'm a very experienced surgeon, so I know what I'm looking for. You know, what you see is not what you get with endometriosis. And that's why I'd say, the non-invasive test, I think, is a great way to go. And I would treat that medically, certainly much more rapidly than I would think about treating that surgically. Now, the only caveat to that is if you've got really painful periods, if things are really bad, it really hurts, and every month you have a really hard time because of all that pain. In that scenario, I say, well, surgery may make some sense, because we can probably make you feel better from that. So in case you don't want to get pregnant right now, then sure, by all means, have a little surgery, see if you can't clean up endometriosis, and that's a scenario I think that surgery is actually more likely to be helpful. Hello to Logan Logan, the therapist in Arkansas, my favorite therapist in Northwest Arkansas. How about that? My favorite therapist in Arkansas all around. And in fact, if you are in Arkansas and you need a therapist, I have a recommendation for you, and that is Logan, the therapist. How you like that little plug there for you, friend? Appreciate you being here. Hi, Stephanie, and your brand new knee. Thank you for being here, Janine. Howdy, and Angela. Hi, how are you? Great to see you here this evening. Kowser, how's it going? Angela asks, if you do a fresh day 3 transfer, why would you need estrace? Isn't that only for an FET? It's a good question. And here is my guess as to why you got put on estrace. So most of the time when we give you the FSH hormone, right, we're giving you some Follistim or some Gonal F and maybe some Menopur, you're building up the follicles in your ovary. The cells that surround those follicles are called granulosa cells, and that's where you make your estrogen. Well, in some practices that routinely use letrozole as an adjunct to stimulation, you will, by definition, have a lower estradiol level that the nurses then see when they do your blood, and they say that, oh gosh, even though your lining was very good, your estradiol level is low. And yes, it's low because when we give you letrozole, it makes your estradiol low. That's how you make more eggs if you're going to use that method. So and then they say, oh, that's low, and according to my protocol, I have to put you on more estrogen. So in many cases, the term there is iatrogenic, which means that the doctor caused it, that the protocol caused it. The most important thing that you can see when you do an embryo transfer is, did the lining itself get thick enough? If it's in an FET, if it's in the time that you started your progesterone, or your lining will be at its maximum thickness when you trigger. So the number of the estradiol really isn't important. Now, there is some data out there that tells us that the optimum estradiol level is between 200 and 600. But if yours is 100, is less than that, that doesn't mean that you're going to do better if we treat it. In most cases, the reason that number is less is because especially if you're in a practice that uses letrozole for part of your stimulation, it's because the letrozole made your number low. And a nurse is treating it based on a protocol without really understanding what that means. So that is probably, I think, the reason why there, Angela. Sheila is here. Good evening to you on the New Life Fertility Instagram side. And hi, Lauren Lucas. Thank you for being here this evening. V. Reese says, hello, Dr. Fink, and hello to you, V. Reese. For those with a low AMH, that is less than 0.7 in our early 30s, what are things I should do or can control before any procedures are determined? I have no underlying PCOS or any other concerns. Well, so let's say, the first question is, let's ask, what does that AMH actually really mean? What is it? Well, what it's not is a measure of whether you can get pregnant. What it's not is a measure of your fertility. What it is not is any sort of tell as to when you may go through menopause, or whether you are perimenopausal, or really anything else. What it is telling us is about the pool of available follicles in the ovary for us to stimulate, were we to stimulate your ovaries. I think it gives us a little bit of a clue as well about, how loud the clock is ticking. So let's say that you went someplace and they said, well, let's just test your AMH to see what your ovarian reserve is. And you tested it and found, shockingly, it's lower than you expected. Maybe that tells you that it's time to perhaps think about doing something like egg freezing, doing something like, well, we were thinking about getting pregnant next year, but maybe we want to expedite that now. Maybe we want to, move a little faster on that. What the AMH, where it comes from, is all those little cells that make estrogen, the granulosa cells that we talked about just a moment ago, that surround each little egg house or follicle. They secrete this hormone called AMH, or anti-Mullerian hormone. And so the more of those eggs you have, the more of those cells you have, and the more of those cells you have, the more AMH you make. And that's what the AMH, that's where it comes from. What does it tell me? What it tells me is, well, first tells me a little bit about timing. Yep. So just like we talked about with the, maybe the clock is ticking, it tells me how loud that clock is ticking. But most importantly, it just gives me some guidance on how I'm going to stimulate your ovaries and on what might be the best treatment for you. So it does not mean that you can't have a baby on your own. Doesn't correlate with that in any way, shape, or form. So the first thing I would say is take a breath, because you know what? It's going to be okay. It's a reflection of as I said, the number of eggs or follicles, the number of eggs that are available in the ovary, in the stimulatable pool in the ovaries. So unfortunately, that amount of eggs is something that is there from the time you're born. And I always say this is a little bit of an unfair situation, because the sperm that comes out from your male partner today was manufactured in his body 3 months ago. Whereas every egg that a woman will ever have in her life is there on the day she is born. In fact, they're there in utero before she is born. And over the course of our lives, we lose some of those eggs to the process of aging. We lose some of those eggs because as the eggs sit there over the course of our lives, the DNA in those eggs becomes less stable. And so as a result, those are a couple of the reasons that it gets harder for us to have babies as we mature. Why do people's AMHs get to be low? Why are they low? And we don't necessarily have a great answer to that, but I would surmise that it has a lot to do with our diets. It has a lot to do with chemicals in the environment, in the water supply, hormones and things, chemicals in our foods. It has to do, my suspicion is, with what goes in our mouths, microplastics, and all those things that may have taken a hit on your ovary there, V. Reese, long before you ever even thought about, maybe even long before you ever even got your first period, is something that could have happened as a child. Sometimes we think that there could be an illness that comes along, maybe some kind of viral illness that you contracted at some point during your life that resulted in you creating an antibody against your own ovaries, which then resulted in a lower supply of eggs being available. Unfortunately, not a good test for that to see, kind of, is there an anti-ovarian antibody? Such a thing is not available in clinical practice. But it can happen. So really the question is, what are things that you can control? Well, what you can control is your egg quality. So what we're talking about here with the AMH may be egg quantity, the number of eggs that are there. Egg quality is something completely different. And so first of all, being in your early 30s, you are already way ahead of the game there, because you will have good eggs. That does not mean that you have the egg quality or the DNA in the eggs that is consistent with whatever age of 0.7 equals to, which is somewhere close to about 40. You still have the eggs of someone in their early 30s. And by the way, it's not uncommon that I see people with an AMH that's on average about 7 years older than their bodies. are chronologically, and that's just because the ovaries seem to age at a pace that's often um, faster than the rest of the body. But what you can do is that there are some supplements that you can take that I think will be helpful for you to be able to help to maintain your egg quality. And what does that mean? Well, our bodies have pretty good DNA repair mechanisms. Anything that we can do to try to help those repair mechanisms is probably a good thing. So, a prenatal vitamin, some vitamin D, some vitamin E. Probably the most important is CoQ10. There is some omega-3 or fish oil is a very important one. Alpha lipoic acid is another one. And the last one is actually melatonin. So these are all things that you can take that will help your body maintain its egg quality, even though as time goes by, we all get older every single day. Help those DNA repair mechanisms keep those ovaries as healthy as they can be. That's really probably the best thing that you can do. Let's see. Jess says, thanks so much. Yeah, BCL6 positive with no symptoms. Happy to finally have answers. Answers are a good thing. And let's see, Amber is here, and great to see you, Amber. I'm very, very happy to see you in Gulf Shores here this evening. I hope you're enjoying a little beach weather. Although, what do we got? Yeah, it's 75 degrees outside. It was chilly here in Pensacola this morning on the Gulf Coast. Yeah, we had some cooler nights, but still nice and warm in the day, and still a great place to be for spring break, I will tell you. And if you're not from this part of the country, if you're someplace else and you're watching, I have to say, coming to the beach in Pensacola, Florida is, especially in the summertime, that beach vacation is unparalleled. Did you know that Pensacola Beach was named the #1 beach in the United States of America? The #2 beach is actually Navarre Beach, which is one beach to the east of Pensacola. #1 and #2 in the United States. So how about that? And the Emerald Coast, which is as you go a little bit further down towards Panama City, so in the Destin area, Santa Rosa Beach and Rosemary Beach, Seaside Watercolor, those places are just absolutely wonderful. And if you haven't been here before, I hope you'll have a chance to visit. And if you do come visit, stop by and see me. I'd love to see you. And by the way, to that point, this week I will be in St. Louis. I'll be doing egg retrievals at the MCRM in St. Louis. That's the Missouri Center for Reproductive Medicine on Thursday, Friday, and Saturday. And in fact, Thursday evening, we will be having a special Fink and Friends, or Fertility with Fink and Friends live event at MCRM, where there will be giveaways, where there will be all your questions, meet and greet. We can talk. You can meet the whole staff. I think we'll probably put that on Instagram. So if you see me back another time this week, it's going to be a live event in St. Louis. And if you're in the St. Louis area, I certainly hope that you can stop by and say hello and maybe even win some prizes, because prizes are a good thing. Hey, folks, half past the hour now, which means it's time for us to do our 5:30 Fuzzies with Fink. The Fuzzies with Fink is that time that we all get together here and not talk about how fuzzy some of us are, but rather the warm and fuzzies. Because as we know, this fertility thing is a rough ride. And I found myself saying probably 3 times today and you may have heard me say this before, it's the crappiest roller coaster in the park. Because you get on the damn train, right? And it takes off out of the station, and it whips you to the left and it whips you to the right. It turns you upside down. It makes you nauseated. It gives you a headache. It hurts your neck from whipping it around back and forth. And all the while, you are so uncomfortable because you don't know. Because of the unknown of what's going to happen when that train pulls back in the station. Are you going to be getting off the train with a lovely parting gift? And that is that baby in your arms. The unknown is a very frightening thing for us. And when we engage in this process, trying to fulfill that need in our hearts and our minds to add to our families, having that unknown there sits as a big shadow. It's like a storm cloud that hangs over us and never seems to want to leave us alone. It can be a frightening thing, and it can be a very, very lonely thing, because sometimes it seems that we are the only ones that are suffering and having to deal with this problem. Well, I'm here to tell you, you're not alone. And in fact, no matter whether the issue is about fertility or the issue is about family, if it's about relationship, if it's about work, if it's about school, no matter what it is, when you're feeling alone, the important thing to know is that someone is always there for you. At this point in our broadcast, this is the time that we stand together as one community and let every last person out there know that they are not in this life by themselves. We're here for you. We're here to answer your questions. We're here to be a shoulder to cry on. We're here to be a voice of reason when sometimes it seems like reason is so remote from where we are. I think most of the folks who watch this broadcast are the kind of people who would bend over backwards, who would, as I say, give the shirts off their back to someone else who's in need, who is going through the same thing that they've gone through. And this is the time that we say, you got this. You're not alone. We're all here together. So let's break the internet with kindness at this moment and send out those positive vibes to everybody tonight who needs them, to all those people who might even think they need them, or how about the people who don't think they need them, but we know that they really do. Whether it's sickness, health, whether it's fertility, or just life in general, you're not alone. We got this. We're all here together. And that, friends, is the 5:30 Fuzzies with Fink. So thank you for participating there. If you would be so kind, ask your friends next week, join in, even if it's just for 2 minutes before the bottom of the hour so they can be here. I would love to be able to say we broke the internet with kindness, because kindness seems to be in short supply these days. All right. Thanks for being a part of that. I said hi to Amber, but I'll say hi again, Amber. Krista, how are you this evening? And Ashley Page, nice to see you. K.N. Davidson, and my dear friend Angelina says, trying to do an FET, ASAP labs show, trying to do FET lab show, a low TSH, T4, T3, free T4, free thyroxine, testosterone, and normal TPO. Could this represent central hypothyroidism? So if the TSH is low, then that usually suggests hyperthyroidism. So remember that TSH, the thyroid stimulating hormone, is an opposite reflection of what your thyroid is doing. And it's an indirect marker. And so what it means is that if the TSH is low, that means the thyroid function is high. If the TSH is high, that means the thyroid function is low. So just remember those opposites as it pertains to thyroid. Now, you've got a low TSH, which is telling me hyperthyroid. Are you saying that the T4, T3, the free T4, the free thyroxine, those are low as well? Because that doesn't quite go along with a low TSH, because if your T3, T4 are low, that's hypothyroid, and I would expect the TSH actually to be high in that scenario. So that way, and when you say free thyroxine, is that a free T3 or is that an FTI, a free thyroxine index? I would suggest, Angelina, a free thyroxine index and a reverse T3. And I think that that may uncouple what kind of mysteries are going on in your thyroid gland. Meeting with endocrine, should I meet with endocrine? If you have classic hypothyroid symptoms. So the first thing I would do, I would get those other tests done because that's what they're going to order, and that will help to unravel that. But yes, in that scenario, let's say that you didn't have access to those tests. I would say that's a complicated enough picture that a medical endocrinologist needs to tease that out, especially if you are symptomatic. So what are the symptoms of hypothyroidism? Well, the thyroid lives here in our neck, and it controls our metabolism, right? So think about metabolism keeping us moving along. So if you're the Energizer Bunny, in fact, take the Energizer Bunny and multiply that by 10, maybe you're hyperthyroid. Maybe. If you're super slow, like you're feeling cold, you're constipated, you're sleepy, your hair's falling out, and actually that can happen either way. You grow hair, your hair falls out. Things are moving slowly, then you think about that as hypothyroid. Now, the problem that many medical endocrinologists have with hypothyroidism is that many of the normal symptoms that are associated with life mimic that of hypothyroidism. So symptoms alone are really not diagnostic truly of any thyroid dysfunction. It is considered to be a laboratory diagnosis, or in the event of a nodule in the thyroid, something that's physical that you can actually feel. Free thyroid index and a reverse T3. That's what I would do there. T. Benvenida, nice to see you. Nobody has said a word here on Facebook, but I see people are watching. So if anybody at least wants to say hi, tell me hi on Facebook so I know that you're out there. Brittany Bug says, hey, Dr. Fink. Oh, hey, Britt and Laney. Hello. Good evening to you. Thank you for being here. Brittany has an absolutely beautiful baby, absolutely a charming child who is right here in my office, and I still have the animal crackers on my carpet to prove it, right? So kisses to both of you guys. Thank you very much. Here's the name, Arhemazan Shar. Do you have a clinic in Toronto? I do not have a clinic in Toronto. However, I do have a wonderful doctor I know in Toronto. His name is Dr. Fayez Faruqi, Dr. Faruqi, and I would say look him up or instant message me here through Instagram, and I am happy to pass that name along for you. By the way, if you're messaging me, it's to the Randy Fink MD Instagram page here. This is New Life Fertility, and that one is checked by some other folks. Kelly, thank you so much for saying hello here on Facebook. I appreciate that. I thought I was talking to an empty wall out there, but nice to see that there are names attached to all those people who are online. Have a wonderful evening, Kelly. Thank you very much for being here. Let's see what else we got here. Gwen is here, as is Adj, I believe that says. Over here, we've got Kelsey, we've got Ocean. Oh, hello there, my dear friend. Good evening in South Florida. I hope you are having a wonderful, wonderful, and very happy spring, because it is upon us, and you, my friend, are dearly missed. Joanne is here. And Dr. Williams. One of these days, I will be able to convince the lovely and talented Dr. Corey Williams, who is the extremely excellent embryologist here at New Life Fertility. One of these days, I will convince him to be able to be on the show with me, or to at least do some recordings. I've been asking him for over a year, and the answer is sure, I'll get around to it. And guess what has happened? You do the math. Zenaida, good evening in South Florida. Thank you for being here and for brightening up the room. As always, that's Zenny 1970. Joanne says, I have an endometrioma. It's 4.3 centimeters, and due to a previous surgery, my left ovary is quiet. Any advice? So I'm assuming that you mean that maybe you had some other surgery on that left ovary. And certainly what we know is that when we do surgery on an ovary, it will lower the egg count in that ovary. So we can measure that by looking at ultrasound and looking at follicles we see in the beginning of the cycle, those little egg houses, which are quite literally a little tiny sac of fluid with a microscopic egg inside. That's a follicle. An egg house, we call it. So we can look at the ovary and see that. We can measure the AMH hormone and we can see that it will go down after ovarian surgery. So sometimes as a result of that surgery, an ovary will have affected its blood supply. And as a result of that, it just may not really give us a whole lot of response. Like when we look at it, we may not see much going on there. We may not see many eggs, or even when we stimulate that ovary, we may not see much happening. So generally what happens in that scenario is that I'd say, you don't want to have, if you're trying to get pregnant anyway, I don't recommend that people go and have an endometrioma removed from the ovary, because what's going to happen, it is, no matter how good or perfect the surgeon is, it is going to take some of the eggs with it. Your egg supply is going to go down. So, when we do something like IVF, I can almost always get myself around an endometrioma in order to get those follicles. It's true that having a big cyst in the ovary, like endometriosis, may have some effect on some mass effect that diminishes the number of follicles that are able to grow. But I will tell you that taking the cyst out is going to affect you much, much more significantly. So I generally recommend, advice is, leave the endometrioma if you can. If you're trying to get pregnant, do what you have to do to go ahead and get pregnant, because we can deal with the endometrioma later. But dealing with it sooner rather than later means that we're also going to be sacrificing even more eggs. And it sounds like you already had some sacrifice there with the surgery on the other side. Kelly Lee is here this evening. I'll be seeing you soon for our second baby. Love watching the videos. Thank you very much. And Maddie May is also here as well. Thank you for your time and effort to help patients. Thank you, Maddie May, for being here. And I just like to say your name, Maddie May. It just rolls off the tongue. I appreciate you guys being here and for speaking up there on the Facebook side. Very much appreciated. Let's see here. What else we got? We've got Doctor, you are the best. Ocean, you say all the right things, my friend. So I should, I could share a little story there, but my history goes back for a great many years with that very nice person who goes by the moniker of Ocean. Great many years when I practiced general obstetrics and gynecology, and I want to say, my friend, it may have even been 12, 15 years ago. And I so appreciate that you still know who I am. That just really means the world. Hello, Mrs. Pittman. Good to see you here this evening. Yeah, so Angelina says all low. So that's a confusing picture, because with a low TSH, you say, nope, that's going to be hyperthyroid. But you've got all the markers of a low thyroid. So free thyroxine index and reverse T3. Claudine for Navy, good evening. And Macy up in the wonderful city of St. Louis. Good evening. Macy is one of the coordinators at MCRM and is not only a fantastic IVF nurse, she is a great nurse. She is a good friend and also really a very, very wonderful person. So Macy, I am flattered that you're here. And I'm told, I'm trying to remember, oh, your husband is a nurse as well. I think you told me he's in the cardiac cath lab. So that is a couple of very special people there that really care about other folks. So let's see. Claudine says, hi. Joanie, we got that. Riri, hi, how are you? Oh, and now Dr. Williams says he'll accept. Oh, sure you will. Lisa in US says, my first IVF stems were converted to IUI on day 9 due to not a good stem response to the medication. My doctor is going to increase the medication dose for my next stems. Well, so that's one way to do it, is by increasing the medication. But here's an important thing to know as it pertains to IVF, and that is that IVF medication is not something that is linear. Right? What do I mean by that? What is linear? Linear means it's a line, and usually we think of that line as going up. So it doesn't mean that the more medication you get, the bigger the response you get. Sometimes you don't get much of a response because the ovaries just don't know how to respond to the medication. Now, it may be that you truly didn't get enough, but in some cases it actually has to do not so much with the amount of medication, but in the way that you're stimulating the ovaries. So here's an example. I'm trying to think of how I can put this. So in my clinic, we use FSH, we use Follistim, and we use typically Menopur. So let's say that we had a patient whose AMH level was, let's call it 0.7. So that's considered diminished ovarian reserve. And normally what many places would do, and what was being done here previously, was that you'd get a really high dose of stimulation in that scenario. You'd get in this clinic, you'd get 225 of FSH and 225 of Menopur. It's a big dose. Really speaking loud to your ovaries, trying to get your ovaries to respond, right? But in many cases, you don't get much of a response at all because the ovaries just don't know what to do with all that information. And so as a result, they don't really give us very much. Well, here's the way I like to handle that now. There's very little evidence that tells us more than a total of about 300 units of gonadotropin is going to give you more eggs than otherwise. So I usually start at about 200 or 225, something like that is a good place to start. I usually add some Menopur in, usually by about day 5 or 6 of the stimulation, because in the beginning of the cycle, those follicles don't need all that stimulation. And in fact, if you give them too much stimulation, they can be fragile and they can just kind of shut down. That one of them may kind of be able to grow, but the other ones, they start to fall away because the one has become dominant. What we really want is to get that group of eggs in the ovary to start to grow together. So what I'm fond of doing is a little HCG LH, usually about 50 to 150 units. 100 is kind of a sweet spot. 100 units of HCG while getting your Follistim or your Gonal-F during the first 5 days. And what that does is that it increases the receptors for FSH on the surfaces of those follicles. So that means you may be able to respond better. Then once those follicles have grown to the point where they've got receptors for FSH and can actually do something, you add in more FSH, you add in your Menopur at that time. So, I caution folks about saying, well, gosh, we're just going to increase the dose and hope for a better response. Doesn't always work that way. A lot of times we really have to think about that as the physiology. What's going on there at the level of the egg? And why didn't your ovaries respond? It may have been because they just couldn't. And that a simple 200 or 225 may recruit the group of follicles that can be recruited. The problem is that then if you give them too much, the group is going to shut down so that a narrow cohort is going to start to grow and may grow more rapidly. So what we want is to get that whole group to grow. And that, my friends, is what I mean by the art of IVF. Let's see here. Yeah, Lisa says if the new plan doesn't work, what are the options? So you know what I would say there, friend, is I think it's worthwhile maybe getting another opinion. So see what your doctor has to say, and then talk to somebody else. It doesn't mean that you have to change clinics. It doesn't mean that you're being disloyal. I would say you're just educating yourself on what does this all mean. It's a new language, right? So this is stuff that you probably really haven't had to think about. Get some advice from somebody else. It's worth the couple $100 that you may have to pay for that advice in order to really understand the nuances of what's going on in your cycle. um Let's see. Mrs. Sirach says, I am a fan as well. What city are you in? Well, if you are talking to me, I am in Pensacola. Also, we have offices in Mobile, Alabama, and Panama City. I am based in Florida, but also work at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. Those are the places that you can find me. My dear Amber says, if I have a normal pregnancy, no complication, and no dramatic health history, and I would say far from you to avoid the drama, is there a good reason to schedule an induction? Is there a good reason not to? I'm 35, I'm 13 weeks pregnant. So the thing about induction of labor, ultimately, it really depends, Amber, on what your cervix is telling us at the time that you get to be near delivery. So if you make it to 39 weeks pregnant and your cervix is already favorable, and there's actually a scoring system called a Bishop score that we can use to tell you if your cervix is favorable. And that means, is it already dilated? Has it softened up? Has it thinned out? Where is the baby's head in the pelvis? And if all those things are favorable, then there is no added advantage to you staying pregnant. And that is the truth at any age. Now you may say, yeah, but I still, I don't want to be induced. Being induced hurts. And it's funny how people say that. No, induction, that's a painful thing, because the last baby, I was not in any pain at all until they came and broke my water and then started me on Pitocin. And then I was in so much pain. Well, guess what? If you're on labor and delivery and you are not in pain, then you are not in labor. That's just the fact. If you are not in pain, then you're not in labor. So what we want is we want you to be in labor. Now, if you're 39 weeks, and we really try not to electively deliver babies before 39 weeks. Now, if there's a medical indication, if there's a reason to do so, then you do so, right? But then that's about the health of the baby. What we know is that pregnancies that go beyond 41 weeks, which is 1 week after the due date, 40 weeks is the due date, those pregnancies start to have problems. Those babies have higher incidence of NICU admissions. There's a higher incidence of those babies dying, even in utero, because the placenta is an organ, just like any other organ in your body, like your liver or your kidneys. Those are organs, right? And those organs have a lifespan. And that lifespan is typically your life, unless you're talking about the placenta. And the lifespan of the placenta is roughly about 42 weeks or so. That's the reason that 40 weeks is considered a due date. The placenta starts to tire out. And the more mature we are by birth date that appears on our driver's license, the greater those risks may be. So certainly if the cervix is favorable at 39 weeks or even 40 weeks if you want to, inducing your labor means that it will happen in a planned and predictable manner. It means you are not at any increased risk for a cesarean section. It means that your own doctor, in all probability, will be able to deliver you and not someone else who is on call for your doctor. So that may be a good reason to do it right there. It means that you're not rushing into the hospital in the middle of the night because your water broke, freaking out, running stop signs, potentially getting in an accident because you're in such a rush to get there. It just makes things more elective and less of an emergency. You know what I mean? And being able to have that planned is often a valuable thing to people, especially if it may make a difference in who's actually going to deliver your baby. But the important caveat there is that the cervix has to be favorable. If the cervix is not favorable, then I don't advocate that delivery or that induction without a legitimate medical reason. If, however, the cervix is favorable, it means that you're at no higher risk and all you're doing is just helping nature out a little bit. So that's my 2 cents worth on that. Logan, the therapist, throws some very useful words here. Fertility struggles can feel so lonely with constant setbacks that even the hard parts but even the hard parts can be steps forward towards finding what works. Hold on to the small wins and be gentle with yourself. Logan, those are great words of advice. Be gentle with yourself and hold on to the small wins. Holding space for all going through the journey. Logan, you are awesome. Thank you very, very much for that. Amber Marlena says, congratulations on your pregnancy. And you can just tell everybody who helped you out with that. Just saying. Oh, you did. Look at you did. Before I even saw it, she says, yep, thanks to Dr. Fink. I appreciate that. Hi, Emily Temple in Mon Orn, I believe that says. And Joanie says, yeah, I started, sadly, I ovulated too early, and sometimes that can happen. Good evening to Aaron, who I believe is in Dothan, Alabama this evening. A special, very special shout out to you and all you do. You are very much appreciated. Bryn, hello and happy evening to you. Let's see, how soon am I able to transfer after a C-section? Well, we really want that C-section scar on the uterus to be able to heal. So most docs will say 9 to 12 months is really what we're looking for. We're looking for an ideal length of time between pregnancies to be kind of between 1 and 5 years. Now, 5 years, does seem like a long time, but physiologically, as far as the babies go, according to the American Academy of Pediatrics, that's what they say is optimum. The scar that you have on your uterus from the C-section there means that muscle is not going to be as strong as it was beforehand. And here's how I look at that. If this bicep muscle of mine, if I can lift 100 pounds, and then I put a scar in that muscle, if I cut into that muscle and then let it heal, maybe I sew it up and then let it heal on its own, the most strength that I'm going to get from that muscle cutting into the muscle is going to be with a 20% decrease. So instead of being able to lift 100 pounds, I can only lift 80. Same thing kind of really happens with the uterus there. And remember, that muscle is designed to squeeze a baby out. The strength of that muscle diminishes. So we want to make sure that that muscle is as well healed as possible. So I typically say 9 months is sort of what we're looking at. Will you be 9 months minimum, I think is probably the safest. Good evening to Max the Gaucho up in Fort Collins, Colorado. Good evening to you, my son. Will you be doing any transfers, Joanie asks, in Albany or Syracuse? No, I don't work for CNY anymore, and those are CNY fertility locations, but you've got great folks up there who can take care of you for sure, both in Albany and in Syracuse. Do chances decrease after a C-section, the chances for pregnancy? No, they don't. You just, we don't recommend that you get pregnant too early because it runs the risk of that muscle. But also, as you may have heard me say before, the only preventable cause of severe preterm delivery is a short interconceptual interval, and that means the interval between the babies. So severe preterm delivery is something we really do want to avoid if we can. I'm Dr. Randy Fink, and I am here at New Life Fertility, and that website is fertilityleaders.com in Pensacola, Florida, also Panama City and Mobile, Alabama, and I also work at the Missouri Center for Reproductive Medicine in St. Louis and in Tulsa. We are out of time this evening. I want to say a really, really sincere thank you to everyone who joined me this evening, who gave a part of themselves to that 5:30 Fuzzies with Fink. Those of you who answer questions and those of you who just kind of hang around. Kelly, that includes you too there. Thank you very, very much. To everybody out there, this fertility business is not the book of your life. It's just a chapter. And what are we here to do? We are here to rewrite that chapter together. So every step forward with kindness, every step forward with love, and really, truly, every step forward with hope. Take the little wins and be gentle with yourself, as my friend Logan says there. Every step forward with hope, because tomorrow is a new day full of all new adventures. I will be live from St. Louis on Thursday evening. So if you're going to be in the area, please stop by, join us, win some prizes, meet the team, and get your questions answered. But until next week, Dr. Randy Fink, thanks so much for being here, and good night.